Okay, that sounds great. So, as you may know, Veritas study, it was a meta-analysis of patient-level data that was recently published in The Lancet, and it basically showed a dramatic benefit for endovascular thrombectomy in vertebrobasilar occlusions, like 2.5-fold increase of good functional outcome defined as MRS 0 to 3. But despite the higher risk of SICH, it was also associated with reduced mortality and overall disability. That was great, and it paved the road for endovascular thrombectomy to be the first line of care for vertebrobasilar occlusion. But sadly, patients with posterior circulation tandem lesions were excluded from most of the randomized trials included in this meta-analysis, while they represent around up to 29, so they represent about up to 29% of the patients from posterior circulation strokes. So our aim at the beginning in the positive study was to see if endovascular thrombectomy is a viable option and trusted option for those patients. And that's what we did. We found that the good functional outcome in those patients is 40%, defined as MRS 0 to 3, and the mortality was shy to 40% as well. And that's quite comparable to the findings from Veritas trial. So we can safely say that endovascular thrombectomy for this group of patients is a good option to consider, and maybe also as a standard of care, because it's ethically hard to do another prospective randomized trial for those patients. One other pressing question we were interested in was stenting versus non-stenting, and here I mean extracranial stenting, and we found that stenting is better than non-stenting in a recent study that we just published in Journal of Stroke. And building on this story, we were testing intravenous tirofiban. So we were testing the intravenous tirofiban for this group of patients with posterior circulation tandem lesion. And when I say posterior circulation tandem lesion, I mean an occlusion in the vertebrobasilar artery extracranial, V1 to V3, along with another occlusion intracranial, V4 basilar artery occlusion with all segments, proximal, middle, and distal, and also posterior circulation, posterior cerebral artery as well. So if you have a steno-occlusive occlusion more than 70% in the extracranial vertebral artery, it also qualified in our study if we have impaired the filling of collaterals on the other side of the vert. As you know, for tirofiban, it's a glycoprotein 2B3A, and it has a short half-life, fast-acting, so it can be used in acute setting compared to oral aspirin or clopidogrel. And in our group of patients, we opted to use it just because we were aware of the Rescue BT trial that was just published recently, which showed that IV tirofiban may not be significantly different than maybe not significantly different than placebo in anterior circulation proximal occlusions. However, in a post-hoc analysis focusing on the ICAD patients, it showed lower number of thrombectomy attempts along with good functional outcome at 90 days. And that made us want to test it in that group of patients that we're studying in the positive study, the posterior circulation tandem lesion group. So we conducted the study across more than 50 centers in China, coordinated with the group there, and we included 126 patients in the tirofiban group, and also included 82 patients in the non-tirofiban group. And in terms of baseline characteristic, we didn't find anything statistically significant or unbalanced, except for age was slightly numerically higher in the non-tirofiban group, and smoking was higher in the tirofiban group, and it was associated with atherosclerosis etiology, which would make sense, as we said, the tirofiban would be working more in the atherosclerotic etiologies compared to cardioembolic, and atrial fibrillation, on the other hand, was higher in the non-tirofiban group. In terms of outcome, we did univariable analysis and multivariable binary logistic regression, ordinary logistic regression. In univariate analysis, we found significantly different short, intermediate, and long-term outcome in favor of tirofiban. And it was numerically higher across all the NIHSS, 24-hour NIHSS discharge, early neurological improvements, and the same for functional outcome, good functional outcome and functional independence, and reduced mortality at 90 days and at 1 year. We did also multivariable logistic regression where we adjusted for the baseline imbalances along with the age and NIHSS. And the results were consistent to confirming a higher value of tirofiban with odds ratios more than 3 compared to the non-tirofiban, showing a great benefit for tirofiban in posterior circulation tandem lesions. So we can simply interpret this data by saying that tirofiban, IV tirofiban, can be a good addition to the cocktail of medication we're offering for patients with posterior circulation tandem lesions. However, there are some considerations. The first consideration would be the optimum dose. There is no research right now that would make it clear what is the optimum dose. We're adopting doses from cardiology and PCI treatment, but we don't have our own doses, so we need more studies to establish the optimum dose or optimal dose for those patients. One other consideration is the selection of the right population. So, for example, the patients with ICAS or the patients ineligible to IVT may be favored for tirofiban compared to cardioembolic, or the patients with who are at risk of bleeding with combined medications. And that's generally the study. It suffered from a little bit of limitation of retrospective design, but it's the biggest study out there focused on this topic. Thank you so much.